We are Össur Academy, bringing you virtual learning direct to your desktop or mobile device, wherever you are and whenever you need it. We believe in the value of appropriate and relevant clinical education and have a wide range of learning formats specifically for you. Whether this is for your own CPD, product insight and awareness, or detailed training relevant to your own clinical needs, we provide a huge range of remote learning opportunities specifically tailored to you. We bring together key opinion leaders sharing insights into orthopaedic and prosthetic clinical pathways, our own clinical and professional sales teams offering you detailed product insight and evidence-based education, large-scale secure webinars professionally managed with multimedia content, virtual fittings and user demonstrations offering remote interactive support to colleagues and customers in their own workplace, pre-requested one-to-one virtual meetings with our clinical teams, providing real-time diagnostics and support, open meetings allowing for multi-site interaction and knowledge sharing. Contact us now to arrange your own virtual training and education meeting, and visit our website to browse our back catalogue of webinars and other online education events. We are Össur Academy, providing your educational needs.
And welcome. Great to have you all back off after the summer break. And glad you could join us this evening for our 15th KOL webinar in 2020. Coming live up to over the last 6 months, showcasing how we can assist you, the customer, with virtual learning and training. So if you do have any requests for that, please do get in contact. So we're back with our KOL webinars with a great lineup over the coming months of KOLs sharing and discussing very interesting topics, including going live from various locations across the UK. So please keep an eye out for those invites in the coming weeks. So tonight we're fortunate to be joined by Mr. Kirti Moholkar of the Royal Orthopaedic Hospital and Droitwich Knee Clinic. So we can go over to Kirti to say hi. Good evening, Kirti. Thank you for joining us this evening. Mr. Moholkar will be discussing patellar instability and the surgical and conservative management options available. Mr. Moholkar will present on the most desired and important aspects of this interesting and challenging topic, discussing the management options in your practice and briefly discussing what treatment options are like when they're handed over to him in secondary care. So we'll go through the agenda. Kirti Moholkar will take the presentation first of all, and then our very own Giles Leeming will be going through an overview and fitting of the new FormFit tracker brace, which was launched the week before lockdown. So I'm assuming that most of you have not seen that. So to help us go through that, we have various camera angles. We have the side camera angle. We also have a front presentation camera angle here, where Giles will be doing the main presentation from the main screen here. We also have a tabletop cam, which will give a close-up view of the new product, the FormFit tracker, and that's Giles Leeming's hands there. And at the back of the room, as always, we have a fitting area where we can go through a fitting of the product later on, and Giles will be fitting that to my leg, hence the reason why I am wearing shorts. So if we go back to the main camera, Pete, thank you. So for many of you who may have joined us or have joined us for the previous 14 KOL webinars, but for anybody who hasn't, just a couple of housekeeping. So how to communicate with us, please use the Q&A function to answer any questions or ask any questions, apologies, that you have for Kirti, and Giles will be manning that throughout the evening. There's also a chat function being manned by Peter Gill, who's also doing the camera angles this evening. So if you would like to say hello, you can't see, you can't hear, then please do put them in the chat box. We are recording this evening's session. It's then posted onto the Össur Academy YouTube channel, usually 48 to 72 hours afterwards. And you will also be receiving an e-certificate for your attendance this evening. Again, that's usually sent out between 48 to 72 hours. Might go into your junk inbox, so do check that. But you can save that as a PDF and then put it into your folder. And there are a follow-up questionnaire as well. So if you do have any suggested topics or any ideas of how we can improve the webinar format, then please do put that as. There is no prizes for that, but please, if you can fill them in, it really does help us out with some feedback. So that's that. So before I pass over to Kirti, if I could just move to the side view camera, I'm going to introduce Kirti. So after training on the North Western and West Midlands Specialist Training programme, Mr Moholkar took up the post of consultant orthopaedic surgeon at the Royal Orthopaedic Hospital in December of 2004. He is now the clinical outcomes lead for the whole of the hospital at the Royal Orthopaedic Hospital. He completed a fellowship from the United States of America and a sports fellowship from Australia. He has a broad base of various aspects of knee and shoulder surgery and a particular interest in total unicompartmental and patellofemoral knee replacement using computer-assisted, minimally invasive approach. So we're very lucky to have Kirti speaking for us this evening. I hope you enjoy the evening. Before I pass over to Kirti, as we always do, we're just going to do a quick poll. There'll be some polls throughout Kirti's presentation. Again, Giles will be manning that for us. If we can just go to the front screen, Pete, just the main camera. Thank you. So if we just pop up that poll. So just to get an idea and give Kirti an idea of who is tuning in this evening, if you could just fill out what is your role. So are you a consultant, an orthotist, a physiotherapist, podiatrist, an occupational therapist, sports therapist, or other? So if you could fill that out, it usually takes between 5 and 10 seconds for everybody to get a chance to tot that up. So if we share the results. So this evening, I think we're back to normality. We've got, I think that's 6% consultants, 10% orthotists, majority of the room physiotherapists, representing 72% of the audience this evening. One podiatrist, so hi to the single podiatrists out there. One occupational therapist, 2 sports therapists, and I believe 7% other, which I think are most of the Össur team. So hi there, nice to have you this evening. So with that, I'll pass over to Kirti. Enjoy the evening. Do ask as many questions as you can. Make it as interactive as possible. And I'll pass over to Kirti.
Very good. Thank you very much, Stuart. Thank you, Össur, for giving me this opportunity to talk about this very complex but quite an interesting subject. Yeah, so let's get into it without further ado. The topic we are going to discuss today is management of patellar instability. Now, I'm going to talk about the conservative as well as the surgical aspects, and I'll try to keep the discussion to non-technical level, looking at our audience, but we've got a decent period of time at the end of the webinar to go for live questions if required. So the patellofemoral joint is quite a complex joint made up of the patella and the trochlea. The congruence is most important, and if it is congruent, patients would enjoy a normal kind of anatomy and function, whereas if there was incongruence, if you like, or lateral tracking, or whatever be the case, there would be problems that will come along, which is basically what is the subject of our discussion today. The articulation is virtually non-existent in full extension to the engagement of the lateral facet that starts when one goes into flexion, and in deep flexion, the medial facet gets into articulation as well. Giles is going to take a small little poll here, so if you wouldn't mind, Giles, thank you.
I've just popped that one up. We're just wanting to see, do you see pediatric or less than 16-year-old patients in your normal caseload? So we've got about 65, 70% of people have posted on that one. So I'll just stop that there. We're at 80%. So just to share those results. So 55%, yes, they do see pediatric patients, and 45% don't see pediatric patients.
Pretty good. The reason I thought that was quite important was because majority of the patellofemoral joint instability, dislocations, or subluxation, what would be the case, present in the very early age group. And if we were to treat this population quite well, I think more than likely we will not see major problems that I'm going to briefly touch on with regards to the complications of leaving problems. I wouldn't say non-attended, but if they were not kind of managed well. So if you see patients who are less than, say, 16 or 18 years of age, majority of these patients would have presented to you if you do see patients in that particular age group. So what am I going to cover today? Of course, anatomy, the hard, bony, as well as soft tissue anatomy. We'll talk about the functional aspects of the anatomical variants of both the trochlea as well as the patella. I'll touch upon the causes of instability. How do these patients present, whether they are acute or chronic, or acute on chronic, or habitual dislocators? How do we clinically assess them with regards to what is the level of instability these patients are suffering with? It could be very mild, it could be major, and we'll touch upon the classification of dysplasia. How do we investigate them by means of radiology, plain X-rays or MR scans or CT scans? And then finally, the management, both conservative as well as surgical options. I make no apologies, I'm not going to significantly dive into the shark territory of physiotherapists treating patients by conservative line of management. I have taken a tutorial from our senior physiotherapist, Leslie Hall, prior to this particular talk. So I will keep the conservative management on the descriptive level, if you like, but I will kind of dive deeper into the surgical management. And finally, hopefully, we shouldn't see these complications, but unfortunately, yes, we do. So anatomy, the PFJ, patellofemoral joint, can be classified as far as the stability or instability into the bony restraints, the static soft tissue restraints, and the dynamic soft tissue restraints. So the bony stabilizers are the anatomy, or the depth, if you like, of the trochlea and the shape of the patella. So if the patella and the trochlea were matching each other quite nicely, the marriage, if you like, of the patella and trochlea would be long lasting. If there is dispute between one of the members, if the patella is not behaving nicely, or the trochlea, there's going to be a problem. The static stabilizers are the very famous medial patellofemoral joint ligament, which is called the MPFL, and the medial retinaculum. Now, these are static structures, whereas the dynamic, the muscular structures are the quadriceps, and more importantly, the vastus medialis obliquus. So this is my attempt to try to describe the bony anatomy, and if I could play the video. So if you look at the depth of the trochlea and the patella, in this particular situation, both of these ones, the trochlea as well as the patella, are absolutely nicely congruent and are articulating quite well. So this is the superior surface, that is the bottom surface, this is the patella, this is the quadriceps tendon, and patella tendon is down in that particular region. If you see this video, from flexion to extension, the patella is kind of behaving quite nicely and is in, if you like, healthy relationship with the trochlea. Now, if the patella was to misbehave and was to be slightly shifty in going out laterally, which would be seen in a second, you will see that the lateral tracking will cause significant issues like that. So that's basically a patella that is kind of slightly shifted laterally. So in extension, it is lateral. In flexion, it goes back into the groove, and that's basically the J sign, as we say. So subluxed laterally in extension to engaged in deep flexion. And that is the reason why clinically you'll have patients who will have significant amount of problem in the infralateral facet of the patella. So if you were to suspect somebody's got lateral tracking or they have patellar instability, the infralateral portion of the facet of the patella is usually quite painful. So what do we see arthroscopically with regards to the patellofemoral joint tracking? So again, this is a arthroscopic picture. That's the trochlea, a nice deep trochlea, and a very well-behaved patella. So both of them kind of engage quite nicely. And if that was to happen with flexion, that's basically the patella engaging into the trochlea, and in extension, it coming off, but still nicely communicating with each other. and that would be a healthy patellofemoral joint. Now, look at the naughty patellofemoral joint, which is the maltracking one. That's the trochlea. The depth is quite good. The patella is probably not as well behaved as that. And if you see it here, I'll stop the video. That's the trochlea, and the patella, virtually about 1/4 of the patella is overhanging the lateral facet. And what that causes is the dispute of the lateral tracking. And based upon the extent of, so again, if you can see it here, the gap between the lateral facet and the trochlea on that particular side is significantly narrowed, which causes a lot of pain for these patients. And as soon as it goes into deflection, the articulation improves. If you see that structure, let me go into that again. That is the plica, the infamous plica, which I'm sure you must have heard sometimes gets snipped. So what would happen if the soft tissue structures, which are the non-dynamic, or if you like, static structures. So this is the lateral retinaculum. There is no muscle fiber, as you know, so it is a very, very tight structure. And there is a video wherein I'm doing a lateral release, and you can see how thick that particular band can be. And on the medial side is the medial retinaculum. Again, there is no muscular structure. So these are, if you like, static structures, which are soft tissue that kind of help the patellofemoral joint. Now, in abnormal type of situation, if, say, for argument's sake, the lateral retinaculum was very, very tight or shortened, or the medial retinaculum was very, very stretched, the patella is pushed to the side. If the medial retinaculum was torn, or if the MPFL was torn, the patella just falls off the cliff, giving rise to patellar dislocation. The next one is the soft tissue structure, which is a dynamic one, namely the quadriceps tendon, and most importantly, the bread and butter of the physiotherapy department as far as knee practice is concerned is your vastus medialis obliquus, which is that kind of bulky structure, which I'm sure you guys spend a lot of your time trying to build up. Now, this is the band of tissue, which is the MPFL, the medial, this is the medial side of the knee. The medial, that's the patella, that's the medial epicondyle. So it is the medial patellofemoral joint ligament. So that's MPFL, which is this one. So if somebody was to have an acute dislocation, there is a huge possibility that they tear that particular ligament. So talking about the functional anatomy, what would happen if your patella was very, very tall or was not engaging with the trochlea as it should? And then we'll talk about the coronal and the sagittal plane, a kind of geometry of the patellofemoral joint. So a patella, which is very, very high, is called patella alta. Now, this is your lateral view of the knee, your femur, tibia, and the patella. And what I've tried to do is hyperextend the knee slightly. Now, you can see that the trochlea is approximately up to about here. And if you look at this particular patella, the lowermost pole of the patella is not even articulating with the trochlea. What would happen because of that is there is no place for that patella to engage. And if this is how the anatomy is, the patella is inherently very, very unstable. And the reason this comes about is anatomically the patella is very high, or people have long patellar tendons, giving rise to virtually, if you like, a condition called superior dislocation of the patella. Now, there is a good paper that can be referenced if you want. I'm going to briefly just allude on that. It talks about acute patellar dislocations and the incidence of patella alta, which is quoted in different literatures and ranges from up to about 25%, and it goes as high as 50%. So it's quite important to ascertain if the patellar height was normal, because if it is abnormal, you got a fighting kind of element, if you like, in the patellofemoral joint, which is going to cause problems. So the biomechanics and the joint reactive forces. we know that patellofemoral joint loading activities will cause patellofemoral joint forces. So that's your quadriceps tendon, that's force or vector going around or along the patella tendon. And the resultant effect of these two vectors is a force that goes into the patellofemoral joint. Now, we talked about there being absolutely no articulation of the patella with the trochlea in full extension. And that is the reason why there is no joint reaction force, or very, very minuscule amount, 0.5 of the body weight that goes through the patellofemoral joint if the patient is in full extension. Get your patient to cycle, it's about 1.2 times the body weight. Now, you may have a person who is kind of suffering with significant amount of patellofemoral joint pain, but does not have a problem cycling. And that's the reason why that they only have 1.2 times the body weight that goes through the patellofemoral joint. If they were to do stairs, suddenly the pathological forces start going through the PFJ 3.5 times the body weight. They go into a deep bend and it's 8 times. And if they were to jump them out, it's 12 times. And most of these patients, if they have had the problem for a significant period of time, they start to suffer with a lot of pain, and they will communicate that all activities, including kneeling, rising from low chairs, or walking uphill, downhill, will cause them problems. And that's basically one of the reasons why. So to talk about alignment, it's quite important, and what it boils down to is what is the Q angle or the quadriceps angle. And that angle is formed by an imaginary line, if you like, from the anterior superior iliac spine to the center of the patella. And that represents the quadriceps pull, if you like. And the second line is from the middle of your patella to the tibial tuberosity, and that basically forms a Q angle. Now, if you or your patient has increased femoral anteversion, which causes internal rotation of your femoral sulcus, that gives rise to a bigger Q angle. And a Q angle, the lower, the better, the higher, the worse problems that the patients will be suffering with. So increased femoral anteversion, external tibial torsion, pronation of the subtalar joint, as well as genu recurvatum or hyperextension, will cause increase in the Q angle and increase abnormal forces that go through the patellofemoral joint. Now, the recurvatum will cause the patella to completely disengage, if you like, from the trochlea, causing it to become inherently unstable. Anteversion will cause internal rotation of the trochlea, and then extorsion again increases the Q angle significantly. So recurvatum and my famous model. So if you were to, so we start off with a knee in full normal straight position, and I'm getting the knee into hyperextension. And as soon as the knee goes into hyperextension, you can see how the patella starts to misbehave, and it goes into it goes into a patella alter type of situation like that. So if you were to, I'll pause that now. So if you see the patella, the trochlea starts about there. The patella is as high as, virtually it's missing the 2 centimeters. In that particular situation, in recurvatum knee, the engagement of the patella with the trochlea is completely non-existent, causing instability, which causes the patellae to dislocate with reference to the trochlea. Over to Giles now again to kind of understand your subspecialty practice with reference to PFJ. Giles.
So just to be clear, is, what percentage of your practice is based on knee issues as opposed to other MSK issues? So it's 10%, 20%, 30%, rising to 70%. Okay, and we have 65% of people have answered, so I'll leave that up for a few more seconds. That's fine, and I'll just share that. So you can see that Most people, the highest percentage, 28%, see 30%. And the next following one after that would be 40%, and 20% with 14%. So quite a spread, but most people would approximate about a third of their caseload would be associated with knee issues.
Brilliant. Thank you, Giles. And that's kind of a cross-section which we see very, very commonly. Now, I feel that our understanding of patellofemoral joint issues is much better now as compared to possibly about 2 years ago, maybe 5 years ago, maybe 10 years ago. It is a very rapidly evolving field. And I think attending these type of sessions, as well as doing kind of, didactic trainings or attending these type of lectures improves our understandings. And my practice is roughly about 40 to 45% patellofemoral joint, and most of my pediatric population, if I was to see it, they would be suffering with patellofemoral joint issues. So I think that cross-section is basically what we see very, very commonly. So going into the causes of why somebody would suffer with patellofemoral joint instability, and again, as we discussed with reference to the anatomical variants, if there could be issues with soft tissues or bony or alignment issues, people will start to see these kind of pathological problems. So if the MPFL was torn, traumatically, shall we say, the patella would dislocate. If the VMO for some reason was dysplastic or weakened, if you like, that could cause a soft tissue reason for the patella to dislocate. The bony reasons, the depth of the trochlea or the shape of the patella. If we talk about malalignment, we did discuss anteversion or increased Q angle. And if it is traumatic, most of the single episodes of traumatic unilateral dislocations are due to MPFL injury. And I think I've got a paper which we'll talk about, which kind of gives a very good synopsis of how acute patellar dislocations can be treated very, very nicely and very, very well. So yeah, we should now go into what is trochlear dysplasia. Now, essentially, we're talking about, is the trochlea deep enough to engage a decently, nicely formed patella? There are various radiological parameters that have been discussed, which is called the sulcus angle. And the sulcus angle is more than 140, which means if the flatness of the trochlea was high, that represents trochlear dysplasia, which is kind of the main factor. And in the radiological world, there are various terms called the de jure classification, if you like, or the crossing sign, or the supratrochlear spur. But again, I will, for the purpose of this particular webinar, keep it fairly simple. There are four types of dysplasia, which is type A, B, C, and D. And again, radiologically, they comprise of a increasing kind of combination of the crossing sign, the spur, or the DC sign, if you like. Essentially, what we're looking at is the medial border and the lateral border of the trochlea deep enough for the patella to engage or not. And if it is deep enough, your patient will have a trochlea which is kind of more like this, as compared to if the sulcus angle was very, very high and the trochlea was not deep. And even to make it worse, they have a cliff or a spur, the supratrochlear spur, as they call it, that makes it a very high grade dysplasia. And the classification was discussed by a gentleman called de Jure from Lyon in 1990. And Giles would have sent you a link to his very classic paper through your chat for your perusal, if you like. So the crossing sign is basically seen here, which is overlapping of the medial and the lateral border of the trochlea. And the bump is basically the depth of the deepest portion of the trochlea. And these are the most important kind of radiological parameters that we in the patellofemoral joint world kind of very much look at or are on a lookout for before we decide about the modality of treatment, if you like. So there's again another paper that is referenced in the chat section, a study looking at pediatric population and how these patients were treated, which is one of the reasons why the poll came about with regards to how much is the pediatric population practice, if you like. So there was a group which was treated surgically and the other group which was treated conservatively only. I'm not suggesting conservative treatment is not good, but timely intervention and moving these patients who are not responding to the tertiary care is absolutely required, because quite a few times, if the conservative line of management is not working and if the prognosis was painted really badly, some of the patients would probably not want to go to the tertiary world, just suffer in silence and only present to us in their third decade. And that happens, unfortunately, so commonly that they reach us. Of course, the dislocation kind of reduces as age goes by, but arthritis ensues. And that is usually because either the patient has never had any kind of conservative line of management, or the conservative line of management failed and appropriate time intervention was not done appropriately. So the study kind of suggests that surgical patients had improvement of the parameters, which was clinically correlating with the results. So if somebody was to present to your primary care practice with regards to instability, what are you going to see? Unfortunately, patellofemoral joint issue is very unkind to young ladies. Most of your patients are going to be young females in their teens. The youngest patient I have is 6 years of age, and I did 2 procedures on her to stop her patella from dislocating. The first one was lateral release and medial plication, and I think she held her patella quite well for about 5 years, but before she achieved skeletal maturity, she started to dislocate again, and I did medial reefing, which we'll kind of talk about. So most of the people are in their teens, but again, they can come in as young as 6, 7, 8 years of age. Most of the dysplastic issues are bilateral. Traumatic are unilateral. So somebody's got to be very unfortunate to have a very high force, push their patella over the cliff from medial to lateral side and tear the MPFL. This happens usually unilaterally, and if that was to happen, if they were picked up appropriately, and if the MPFL was reconstructed, these patients will more than likely never have another dislocation. I'm presuming that their trochlea is normal and that the MPFL has been reconstructed well and that it was done timely. So MPFL reconstruction needs to be done, in my opinion, within a couple of weeks. I think as soon as weeks and weeks and weeks go by, the secondary factors start to basically come in and the result of surgery kind of reduces as such. Atraumatic issues arise if they are dysplastic. So these patients who have dysplastic trochleas and abnormal patellas and high patellas and high Q angles don't necessarily need to have a traumatic episode. They will communicate with you that the patella is just subluxing or going out without them having to do anything specifically. They don't necessarily need to present with the patella virtually going out of the joint. Sometimes they will come up with a sign or symptom of instability. They'll say, my knee is just going under me. So it is for us to kind of dissect with regards to what is truly happening as far as that instability episode is concerned. And let me highlight, there are some patients who, if there was a traumatic event, and even if the history was correlating to the patellofemoral joint, their anterior cruciate ligament needs to be assessed quite well. I've treated a number of patients who basically have patellofemoral joint instability, maybe traumatic, maybe dysplastic, but also go on to, of course, after a decent episode or an insult, if you like, of an injury, that they have anterior cruciate ligament. So if you're coming across a patient who talks about instability, of course, PFJ needs to be assessed. Of course, their cruciate ligaments need to be assessed as well. And an eye out for the height of the patella. What is the trochlea like? And with possibly 4, 5, 6 years of experience, you would be able to clinically assess that the patella is tall and the trochlea is dysplastic, and you will be able to assess what the Q angle is like, and if your VMO is not functioning well, or what will be the case. So the dislocations could be acute, which is they were minding their own business quite nicely, something happens, and traumatically, i.e. a force, shall we say this one, a force pushing the patella from the medial side to lateral side, tearing the MPFL, patella falls off. Now, if we were looking at more of this type of characters, wherein people are in their first or second decades, females, and if they have one of the factors that we've kind of talked about, they could dislocate multiple times, and it might be quite chronic. They might have had 5, 6, 7 dislocations. Crosby makes a very important point. So again, that paper has been referenced. So if you're interested, please review that particular paper. MPFL incompetence. So if somebody is presenting with multiple episodes of instability, their VMO as well as the medial retinaculum and MPFL would more than likely not be competent. There's a condition called habitual patellar dislocation, which means that the patella comes back into a normal position in full extension, and in every flexed position of the knee, the patella dislocates. So it kind of is a rule that in full extension, the patella is normal, in flexion, it goes out. So it's habitually dislocating with every act of flexion. So how would you assess a patient who is presenting to you with instability, and it could be related to PFJ, or what would be the case? So of course, detailed history taking is a norm. When you go to clinically examining them, you may find that the patient has swelling or effusion in the knee. And that more so happens if your patient has had an episode of instability, which kind of goes into maybe a week ago, maybe maximum 2 weeks ago, which causes an injury to the synovium, if you like, or the medial retinaculum, causing a hemarthrosis in the knee, or a sympathetic effusion if it is a recurrent type of thing. But again, effusion is not a norm. If the patients have multiple episodes of instability, they might not have any effusion at all. I've seen habitual dislocators, as well as people who are completely dislocated into the lateral gutter, and they've never inhabited their normal trochlea. And those patients will certainly not have any effusion at all. So effusion is not a rule, but if it was noted, you need to kind of, tick a box, if you like. The quadriceps muscles or the VMO, if it is wasted, that kind of tells one about the state of the dynamic as well as the soft tissue static structures. If the patella was high or not, clinically, it can be assessed, but if you can't, the radiological parameters will definitely kind of clarify that. Apprehension test. Now, it's quite a sad test, if you like. Principally, what you're looking at is a patella which is quite unhappy. It has dislocated before, and you're kind of saying, look, I'm going to push you over. Are you going to be unhappy? Of course, it's going to be unhappy. Apprehension test is you're trying to push the patella from the medial to lateral side, and you're looking at the patient as if the patient is going to stop you. Of course, the patient will stop you, or the muscle will go into spasm. Now, please beware, you don't want to dislocate your patient in the clinic. So apprehension test, it's exactly the same thing in shoulder instability, if you like. Apprehension test can be diagnostic, but please do it with a bit of caution. With apprehension test, spasm in the quadriceps, or the patient stopping you because they feel as if the patella is going out, is kind of quite conclusive of a pathological instability, if you like. The lateral facet tenderness, the more instability episodes they have, the more lateral tracking intensity they have, the higher would be the facet tenderness, if you like. Initially, which is when we should intervene, they will not have lateral facet tenderness. Now, results of surgery at that particular stage, provided the conservative line of management is failed, is very, very good. I suspect, give it another 10, 15, 20 years, we will stop seeing patients who have patellofemoral joint osteoarthritis because we maltreated them or we didn't understand the problem, because it was a problem about 20 years ago. I have heard people say, look, it's a patellofemoral joint issue. What are you going to do? They are going to do badly anyway. No, we don't say that now. We very actively say, look, manage them properly. These patients would be, unfortunately, they might need MOTs at a regular interval, but I don't think they will be a candidate who would come to you in the 4th or 5th decade pulling their hair out because they've got significant amount of pain. They don't have bone and bone arthritis, and nobody's willing to kind of do anything about it. I think if you were to treat them well on time, I think these would be very, very happy people. Diagnose a J sign if your patient was having J sign. Q angle can be appropriately measured if patients are standing with valgus, and if they have anteversion, or if they have pronated feet, confirmed by the thigh foot angle, if you like, or the foot progression angle, that also signifies the high Q angle. Now, we had a very, very good and intelligent physiotherapist called Jim. I won't take his second name, but a fabulous guy. You know, this was his technique of assessing, excuse me, the medial / lateral retinacular tightness, if you like. A different way of kind of assessing that is in the picture on the lateral side. You could see if your patient has more anteversion, if you like. So if the internal rotation or the medial rotation was restricted, that kind of signifies that your patients may be suffering with increased anteversion, which causes high Q angle, which causes instability, as we discussed in the past. Okay, so presuming that the patient has been referred, if you like, for secondary care, what we will start doing is start investigating them with, firstly, clinical examination, as we said. And if I feel that there is any degree of trochlear dysplasia, or the patella was high, or combination of all these items, I will start with a plain X-ray first, okay? And that is going to be an AP, a lateral, and a skyline view. And the skyline view can be taken at about 30 degrees and 60 degrees. And I'll show you a couple of pictures which kind of depict the abnormality quite clearly. If I feel that I am looking at a certain amount of problem, then is when I'll go on to an MRI scan. Why do I get an MRI scan? I want to assess the trochlear depth nicely, but more importantly, I want to see how much is the secondary damage to the cartilage, because if the cartilage was preserved and if the patient goes on to have an operation, the result is going to be very, very good. By the time the patient has come to me, they are suffering with pain. By and large, the subchondral changes or the hyaline cartilage is damaged. Now, better late than never, but I would say when the patient presents, if a patient who's suffering with instability has pain at the time of presentation, I can tell you it is a delayed referral. So it is quite important that referrals need to be done timely, or conservative line of management needs to be started quite appropriately. If the MRI scan shows a few parameters like the trochlear dysplasia or the cartilage issue, I would organize a CT scan, and CT would be reserved if that patient was a surgical candidate, because quite a few times just with MRI scan, if the dysplasia was very low grade, I might just feel that my physiotherapy, I mean, Leslie is an absolute gift to the Droitwich Knee Clinic. And what we do is, if we have a patient who we feel is not a surgical candidate, she will virtually do as much as is required to get them rehabilitated appropriately. And we've the Droitwich Knee Clinic is celebrating its 32nd anniversary. And I think, Leslie is the longest serving member of the clinic. She's got significantly well-honed protocols that she will subject them on our patients, virtually stealing them off surgery. And we feel proud of it, that if we have low-grade patellofemoral joint sufferers, they do not need an operation. It's only the high grade that fail conservative line of management that may need something doing. Sulcus angle, it is an angle that will be assessed on a skyline view. Patellar tilt, likewise as well. Insal Salvati index is basically a measure of what is the height of the patellar tendon and what is the height of the patella, or kind of loosely put in is your patella alter. And the index is 1.02 for Insal Salvati, or 1.2 if it is abnormal as far as that particular index is concerned. There are a few more indices that can be measured, like the Caton de Champ, or the length of the patellar tendon over the length of the articular cartilage of the patella. That is kind of complicating issues too much, but essentially all these parameters will give me, the treating surgeon, kind of a gauge of what is the height of the patella. Okay, yeah, so that's basically how the 30-degree view of the trochlea and 60-degree would appear. So if you can see that trochlea, goodness me, that is not a trochlea at all. That's absolutely flat. So how on earth would this patella be happily married to this flat trochlea? The resultant is the patella falls off the ledge. The point I want to make is, this is a patient, I think if I get it right, probably in their 5th decade. Look at the osteoarthritis. She has never had any treatment whatsoever and has had multiple episodes of instability. The instability kind of stopped at, I think, in her 3rd decade, and it was pain that I cannot take anymore, which causes them to present to us, and it is too late. So their patellofemoral joint is completely bone on bone, whereas the rest of the joint is quite good, and there is hardly anything that we can do for them. At 60 degrees, again, we can see that there is a bit of a depth of that particular trochlea, but again, still a very, very abnormal one. Okay, so going towards management, and to begin with the conservative line of management, again, I will, for description purpose, kind of describe what in principle is what we recommend. Flexibility, assessment of it, we do gauge their kind of joint laxity or the soft tissue element of, may it be VMO or the MPFL. We also look at their quadriceps strength, and if their quad strength was not very good, they will not get anything until we were to get a very good quads before we can move them forwards. So we do have a protocol by which we would gauge based upon the time, based upon their quadriceps strength, based upon the function that the quads is delivering. We say a yay or nay with regards to moving the patient forward. It's not that we give them a sheet of exercise to do, the patient goes home and communicates that it is not working. That just doesn't work. We also look at the structures, whether they're tight or not. Aspiration of the joint is required if, say, for argument's sake, they had an effusion. The strength from the time we subject them to Leslie's treatment, if you like, can take up to about 2 to 3 months. So I do firmly believe that patients need to be given time. You can't give them physiotherapy and give them 2 weeks and expect that they will come back with a pumped up quadriceps or VMO. It doesn't happen that quickly. Core stability is quite important, and if the stability was not there and if the patella was kind of slipping out all the time, taping can be done. I won't teach grannies to suck eggs, but just briefly, I'll talk about the principle. Closed chain is better than open chain, because open chain will just kind of get more recruitment of abnormal fibers, if you like. Gluteus is very, very important to strengthen because it does increase your Q angle if the gluteus was weak. Pronation can be improved by insoles. and a very tight retinaculum can be stretched and can be helped. If the dislocation was acute, you could immobilize them, but immobilization can cause stiffness. If you mobilize them early, they can redislocate. So the balance is in between immobilization and mobilization, really. I think Össur are going to showcase a fantastic brace I believe they have in a bit of time, which is a patella-friendly brace. I've not used it because I think it's recently been launched, but that may prove to at least help the patients who are dislocating quite frequently. And then certainly you guys are good kind of tapers, if you like. So taping can also stop dislocation. So stretching of their quadriceps. Young Leslie trying to showcase stretching, taping. Again, the glide and tilt taping. I won't go into the depth of it. Can't stress enough when they are doing their exercise, the hip over the knee, over the ankle principle is extremely important, because even done abnormally, this itself will increase the patellofemoral joint force into an abnormal amount, which is taken quite unkindly, if you like, by the patellofemoral joint. So another poll, over to you, Giles.
So this is, do you write a follow-up letter to your referring surgeon? Yes, no, or sometimes. So do you communicate your treatment back to your referrer and let them know how you've got on with that? So we've got about 50% of people have responded. Give it a little bit longer. Okay. Perfect. So I'll just share that with you now. So 55%, yes, they do write a letter back to the surgeon. 11% don't, and 34% write sometimes.
Okay, right. So I'm sorry to ask that particular question. It's kind of a tongue-in-cheek type of thing, because our experience has not been very, very good. Because what does tend to happen is, imagine I have a patient who's basically from a distant part of the clinic. I mean, DKC has been there for about 32 years. We've got patients who basically come from all nook and corner of the UK. And if they were from a radius beyond something like about 30 miles, we do recommend that they should basically see a local physiotherapist, not our physiotherapist, because it is just absolutely inconvenient. Very, very often it happens that these patients they might have had fantastic treatment, but we have absolutely no way of knowing exactly what has happened. So the patients come back and we need to basically say, okay, tell me what was the treatment that you had. And it becomes quite frustrating for the patient as well as for us. And that's basically our attempt to try to virtually kind of sing from the same hymn sheet, so that we're working on the behalf of the patient. And my humble ask is that physios write to their referring / treating surgeons, because you guys do fantastic deed for the patient, but if we don't know, it is very, very difficult to understand. So we started this particular plea of trying to address this particular problem of having physiotherapists, if you like, on our panel, so that if we're coming across a patient, let's say for argument's sake, a patient from Wales, who's come to us and we have treated him or her, and they need to see a local physiotherapist. It is impossible at this point in time to get a referral letter back. Intention would be that in that particular area, this is our website that we have basically put together, that we will have no more than two very specialist physiotherapists on our panel, if you like, on this particular site, so that we would say to a patient, look, you're from X part of the UK, go onto the website, review the site, and look for a specialist physiotherapist. Intention, request, ask is that when the patient comes back to us, he carries a referral letter. And I think the patient would be happy, we would be happy, and I think we would be providing a very, very good treatment to the patient. So this has taken us about a year and a half. I think last year we did have some virtual face-to-face meetings with local physiotherapists that we work with, but it has taken a long time, and apologies to put this together. But yeah, we are going to populate this particular site. So the site is called meetyourphysio.com. And if you were interested in the collaborative working, if you like, I think the email is info@meetyourphysio.com. The principle is that, you know, this is the site for the patients. We need knee specialist physiotherapists for treating knee condition, if you like. If you're a back physiotherapist, we've got back surgeons. They also would be looking at the same kind of platform, if you like. There are 10 free spaces, and they would be going for 12 months. This is an educational site. They will be required to write an educational post for the patient. Leslie is burning the midnight oil at this point in time and is doing all that she can with regards to the blog post. We will not have more than 2 or 3 physios per location. This is not a commercial site. We're doing this for the patients. We will only have 2 or 3 to give patients a decent amount of choice, but at the same time, not make a commercial venture out of it. Cross collaboration would be absolutely well done here. And as I said in the past, the review letter requirement is extremely, extremely important. So going swiftly to surgery, if the conservative line of management is failed, the patients would need an operation. If as a complication of a dislocation, they suffer with a fracture, which I've seen quite a few times, they need an operation because they form a loose body, or they have a acute tear of the MPFL. Lateral release, which is a procedure I'm sure you have heard. In fact, it is used more often than not. This is the medial side, that is the lateral side. And I will come in from the lateral side with my burning machine, if you like. That is the tight retinaculum, and this is the burning diathermy. You can see I'm cutting away the lateral retinaculum. The lateral retinaculum is quite a thick structure, so I've gone through the superficial layer. See how the retinaculum gapes open, and then in the second go, it is the second layer, and in the third go is the third layer. So look at how thick the retinaculum is. So I would say don't blame yourself if you were trying to stretch the lateral retinaculum and it was not stretching. It is a thick structure. Medial plication, that's the medial side of the joint. That's the patella. These are the sutures, and I take up to about 5 sutures. In my experience, it doesn't really work very, very well, but it's quite a good technique for patients who are skeletally immature and are dislocating, and we can't do any bigger procedure because their physes are still closed. So it is a good procedure, but again, doesn't work all the time. MPFL, again, a very topical procedure, again, in my opinion, done more than what it should be. Can be done in skeletally immature patients. Laxity kind of is a rule if they have MPFL issues. TTTG distance of less than 20 would be kind of a good reason if they don't have any other issues. If they do have other issues, doing an MPFL to hold the patella and yank it to the medial side would only cause them to have osteoarthritis in the future life. So MPFL as a procedure done without thorough assessment of the other parameters is not a great treatment option. The trouble is pain and instability or osteoarthritis in the future. Because of the constraint of time, I'm going to very quickly move on over these papers. I think a good resource to talk about MPFL, and there is, this paper is very, very good because it shows that in well-indicated patients, you can, through MPFL reconstruction, correct the tilt angle as well as the lateral shift ratio. My favorite procedure, the tibial tubercle transfer. You can virtually transfer the tibial tubercle anteriorly as well as medially, and by doing so, you can change the Q angle. Giles, could we take that poll? I think that's probably the last one. So yeah, thank you. Over to you.
Just to be clear, Mr. Moholkar, is it with regards to which patients you've treated from the following operations?
Yes, yeah. So just to make a point that rehabilitation protocols and pathways are quite important, and if people are very well versed with treating patellofemoral joint issues, then they would be fantastic in dealing with these patients. But if they're not, the only thing they need is to to talk to the surgeons or the hospitals to basically say, look, we have not treated these type of patients before, send us your protocol or pathways, and we would be very happy, because if the pathway was not followed appropriately, I think results might not be very good.
Okay, so we've had about 60% of people responded. So have you treated patients with the following operations? You can click as many of these as do apply: tibial tubercle transfer, lateral release, MPFL reconstruction, and trochleoplasty. So I'll stop that there. We're at about 70%, and then share that. So you can see tibial tubercle transfer, about 50%, sorry, 49%. Lateral release, 87%. MPFL reconstruction, 70%. And trochleoplasty is about 22%. So
yeah, that is great, because you know, I mean, I still remember, you know, a similar type of talk that I did maybe about 7-8 years ago, and the amount of people who were seeing trochleoplasty was absolutely minuscule. So I think, no, that is absolutely great. So tibial tubercle transfer, this is one of my patients. So if you look at the placement of the patella, very high, that's the lateral side, and look at the patella, very lateral as well. Following the tibial tubercle, look at the height of the patella, and also look at the positioning. The patella has been dragged onto the medial side, okay? So the patella was high, is low now. The patella that was lateral is into the center. Anteriorization of the patella, if you look at that patella and this one, you can virtually see that the patella has been kind of, if you like, tilted slightly to reduce the patellofemoral joint forces. I would skip these, this paper. It's in your chat box if you wanted to have a look at. Both of them say that the tibial tubercle transfer in properly indicated patients will deliver quite good results. De-rotation osteotomy, I'm sure you must have seen some patients who've had these type of procedures. In my experience, I've never had to do any de-rotation procedures. The Lyon group, who kind of are the proponents of patellofemoral joint surgery, do very little de-rotation osteotomies either. So I've got very limited experience, and in my opinion, very few patients kind of need it. The final couple of slides on trochleoplasty and dysplasia. If your patient has what is called A type of dysplasia, MPFL is a good treatment option. If it is the B or D type of dysplasia, the de jure classification, the deepening trochleoplasty, again, I'm getting too technical, but for descriptive purposes, it's trochleoplasty beyond B, for B and D. But if it is the C group, then the different type of trochleoplasty along with MPFL. So again, one size will not fit all. Trochleoplasty is a very subspecialized area, and done well, I think the results are very good. This slide is saying to avoid delaying patients who are suffering with patellofemoral joint issues. This is an MRI scan view. The trochlea is very flat. Look at the lateral subchondral signal. This patient presented with significant pain and multiple episodes of instability, has had at least about 50 sessions of physiotherapy, 50 sessions of physiotherapy over 3 years. There's a MPFL that is being seen here, which can be seen, and usually the tear pattern can be in the region of about 60%. Complications, I hope we don't see them. Look at the trochlear hyaline cartilage piece that has fallen off because of patellar instability. Look at the subchondral changes that happen with instability. Again, look at this trochlea, completely flat, subchondral changes, patella is completely dislocated. Articular cartilage that is split because of multiple episodes of dislocation. That's the infamous plica. And the final unfortunate issue of patellofemoral joint osteoarthritis due to multiple episodes of instability. Of course, we can do patellofemoral joint replacement, but I think if you were to catch them on time, hopefully we should not have to do patellofemoral joint replacements, because I'm sure you guys know that the result of total knee replacement is pretty good. Patellofemoral joint arthroplasty does not universally deliver very good results. I think we could skip that last poll, Giles. The references are again they've been delivered onto your chat box anyway. I think that's probably it. All over to you, Stuart and Giles. Apologies if I've overshot my my limit.
That's okay. Not to worry. That was fantastic. If you have any questions for Mr. Moholkar, please get those through. I'd just like to start with one from Tim Powell. And he's saying, do you or your physiotherapy team use an objective method to measure quad strength, such as isokinetics or a dynamometer, for example?
I wish Leslie was here and she would have probably stumped you with her answer. The very quick answer is no. We used to do that. But I think it's basically the look and feel that that we kind of at this point in time review on it more as compared to not.
Okay, fantastic. And you've mentioned a couple of times about patients that perhaps have been sent through to you perhaps a little bit too late. Obviously, there's a lot of patient input with that, but are there any sort of diagnostic sort of measures or things that you would really suggest that at that stage they need to be referred on to your care?
I think the group that we have here, who's kind of seen significant and several patellofemoral joint suffering patients, I don't think we'll have any issues with this type of group. But I think usually what I would suggest is if somebody was to talk about instability, unless you ruled out patellofemoral joint and anterior cruciate ligament issues, and if they failed conservative line of management, I would say probably you should have them in your practice for about maybe 3 odd months. Now, beyond that, if the problems don't go away, I think you've got to refer them on, because if they've not had joy out of 3 months of rehabilitation, I think that would be appropriate time to refer them on. Of course, needless to say, you've taken a detailed history, you've clinically examined them, and you've kind of seen signs that are suggestive of instability. So yeah, move them on if you feel that you're not contributing or the patients are not kind of, getting the results, if you like.
Okay. There's a question from Constantana. What would you suggest post-op protocol for MPFL reconstruction? And do you suggest range of motion braces to restrict flexion in the early stages of rehab?
Yes, very, very good question. I hope you've not seen anybody who's had a stiff knee following MPFL reconstruction. Unfortunately, very common. And I think indications need to be really seen. If you've seen a good indication, our protocol, to answer your question straight, is I keep them immobilized in a dynamic brace and I restrict their flexion from 0 to about 40 degrees for the first 2 weeks, 40 to 90 the following 2 weeks, and 90 to full in the final 2 weeks. Now, I'm confident that my MPFL is not going to get ripped out on the table because I take the knee, after I fix the MPFL, I take the knee into full hyperflexion and make sure that I've not over-constrained the patella and that my fixation is not going to come apart. So my immobilization is more for Leslie to work with the patient and get their VMOs firing appropriately and get their glutes working quite nicely so that the primary stabilizer doesn't become MPFL. It's their muscles that basically kind of take it over, and done in that particular fashion, I'll tell you, you will not have a person who will have a stiff knee. Now, when I started, yes, I did immobilize them I never have put them in a cast, but I used to immobilize them from 0 to about maybe 20 degrees for 4 weeks. I did see very mild stiffness issues, and that basically meant that they were struggling to get flexion beyond something like about 6 to 8 weeks time. But with our current protocol, yeah, we don't have a huge issue. And I would say by about 3 months, I think they should have achieved full flexion. And if they don't have full flexion, then I would, Leslie will basically knock my door by the end of maybe 6th, 7th week, 8th week, 9th week, if you like, and say, I think this patient is struggling. I don't remember we having that issue for a very long time. So I think, yes, it's a good question. Yes, it has to be immobilized, but not with a view to stop the MPFL from falling apart. It is with a view to getting them muscle trained.
Okay, fantastic. Well, I think that's probably it for questions for now. If you do have any other burning questions, we can always pass them on to Mr. Moholkar. So what I'm going to do now is just show you the form fit tracker, show you a little bit of information, and then we'll briefly come back to Mr. Moholkar before the end. This was a brace that was released just as lockdown happened, so you may or may not have seen it. But I think given Mr. Moholkar's talk, it's a really good time to talk about patellofemoral bracing. So I'm going to talk a little bit first of all about indications, how the brace works, the features and benefits, a little bit of technical information. I'm actually going to fit that on Stuart. So he already mentioned he's got shorts on this evening. So it's the form fit tracker, and it's indicated for knee conditions that may benefit from realignment of the patella. So this can be patients that would benefit from added lateral support, whether that's through lateral patellar subluxation or dislocation or lateral maltracking. And in terms of how it works, effectively we have the straps that are pulling via a buttress in order to locate that laterally displaced patella more centrally. So you can see that we're using a polyurethane buttress in order to shift that more medially and get it to track more centrally. From a features point of view, it has hinges or custom fit bars that are placed in these lateral sides. Those are completely removable, so you can take those out should you need to. It also has silicone lining inside. So underneath both of those, the custom fit bars, there are silicone dots in order to keep it in position. The way that the patella control actually works is that you have the combination of a reflex wing buttress, which I'll show you in a second, and the power lock strap. So effectively, these pull around and they're pulling that patella across. And this is all used in a flyweight fabric, which is very soft and breathable. So it just means that you've got a small, low-profile brace. It's going to fit underneath clothing. And you'll see in a second, but effectively the whole brace is about 23 centimeters. So nice and compact, real range of different sizes. So from extra small up to triple XL. And we're sizing these from a circumferential measure 15 centimeters above and below mid patella in order to give you the size. So what I'm going to do now is just pop over to the other camera and just show you the brace itself. So I'm just going to open this here, place this out here. So first of all, we have the instructions for use, very important, fitting information are on there. Inside the brace, you've also got a washing bag. So if you look at this, we can actually completely machine wash the brace itself, place it inside the bag, and a 30-degree gentle wash you can do with the whole brace. Just make sure that you've fastened all those straps before you do it, so the Velcro doesn't catch anywhere. And you can see nice compact brace. And what we've got is the straps coming all the way round, and you can see that we have the reflex wing buttress underneath. So you can see in this region here, we've got the buttress, which is detachable, and also you can shift that around. That's got very, very strong Velcro on here. And you can see that there's just a marking there so that you can actually position this here. And in this case, we're also going to remove the cover from the top. So there's quite a lot of adherence from here. So from this polyurethane bumper, places into position, and you can see that this is a right-hand brace positioned on the lateral side, and we're placing the straps all the way around. There's single markers on there, so single white dot for them fastening it, and then again, exactly the same at the top. So double white dot, and they can actually fasten it. So what I'm going to do now is just go over to Stuart. I'm going to pop some PPE on before I do that, and we're just actually going to fit this brace. So excuse me one second while I pop my mask and gloves on. Okay, so I'm just going to go over to the other camera. Stuart's going to slide this onto his leg while I'm putting my gloves on. So my colleague Pete is on the camera, so he can just show you exactly what we're looking at. So if you look, first of all, we're sliding this up into position, making sure that we've got this position nicely over the patella. So you're just marking that nice and centrally. Very simple. We're undoing these power lock straps either side, and you can see that really accurately exposes that reflex wing buttress. So it has these contours in it, so that it will actually contour to fit the shape of the patient nicely without it buckling. So you can effectively position this wherever you would need. So depending on the patient, dependent on their anatomy, you can adjust this according to their positioning. Because what we want to do is just be anchoring it on that lateral side of that patella, and then bring this round and into position. So you'll see the strap comes around through a loop and comes out the back like this. And when we come to fasten this, the one dot on the one dot there, and then these also have a crocodile Velcro section. So what we can actually do in this case is I need to just gently shorten these, and I'm going to place this into position on Stuart's leg. So ideally, we want it to be positioned nice and centrally in this Velcro section. So about there. So you can see I've still got some adjustment left if needed to adjust. And again, bringing this one round, adjust it if required, and we're fastening it nice and centrally here like that. So nice and low profile. And obviously we can remove the hinges on the lateral sides if we need to. So that can be particularly useful if the patient just wants to reduce any bulk. If you just stand up, Stuart, and you can see we've got a good low profile fit, will fit underneath clothing if needed. And we've got a good level of control. And we may actually just need to adjust it once you've actually got the patient stood. You can make small adjustments as required in order to get that position correctly. So there we go. Okay. So perfect. So that really concludes this evening's session. What I'm going to do is just double check if there are any further questions for Mr. Moholkar. There's a quick question from Gemma Cassidy. Is just saying, can you use these for patients with latex allergies? Yes, it doesn't have any latex in it, and it does form part of the form fit range. So we have a variety of patellofemoral related products, whether that's from sleeves all the way up to higher levels of control, such as the form fit tracker. There's just a question, Mr. Moholkar, with regards to, do you see patients with medial subluxation at all?
Yes, we do. And unfortunately, most of the medial subluxers are overzealous lateral releases, shall we say. So we do see them, and quite a few times we have to go back and reconstruct the lateral retinaculum. So it is rare. We can see them. We do see them, but it's quite difficult to treat medial subluxers. I would also say that quite a few times patients would say they sublux medially. It might not be true. So you need to truly assess them and make sure that they are truly subluxing on the medial side. Of course, patients don't read books and they don't know exactly what medial and what lateral is. So answer is, yes, it is possible. Difficult to treat if it is true, but has the patient had lateral release is quite an important thing to ask. There's one more question there. How do you treat patella pain and instability in equal measure? The first thing I would say is, I'm going to say, goodness me, it's been left alone for a wee bit longer. But having said that, you've got to move on and do the right thing for the patient. I would say, assess, analyze the patient, plan a treatment option, and get on with it.
Okay, fantastic. Well, thank you very much for your very interesting talk this evening, Mr. Moholkar. Really appreciate that. Just remains for me to point out the next session, which is in 2 weeks, on the foot and ankle and gait. And this is from the Biomechanics Clinic, and it's Ian Sadler. So there's a link in the chat at the moment. So if you want to go and register for that one, we'll be very pleased to see you. And we're actually traveling to, one of our colleagues is traveling to that clinic, and we'll be doing some of the session from there, combined with some from here as well. So thanks again to Mr. Moholkar. We will see you in a couple of weeks. Thank you for joining us this evening. Thanks.
Thank you.